the antrum?
It's in the receptor in the body.
Now this is actually quite a big growth. Here we can see that the growth is very big growth that is there at the antrum. Sorry, I mean at the lesser curvature starting from G junction. And as I said, there is some doubt about even the crust of the diaphragm. But that part probably crust of the diaphragm we may be able to resect. So here if you look at this. So this is
Yeah,
all the
we can
growth that
see
you are
the
seeing.
lesion being seen there. Extraserosal, we can
Yes,
see the
it's a
extension
extra
there.
serosal. Extra serosal. And there is some doubt
And
about
it
the
is extending on to the left, right crus.
yes, sir. Yes, right crust. But that crust part will come actually because it's not extending too much onto the crust. It's only a little partially only. That part we could have resected. Uh, but now thinking that it's an adenocarcinoma, most probably it's adenocarcinoma. It doesn't. I mean,
Venkat,
But
you have done
there
a
is,
mini lap. You have taken a small incision.
sir.
You have taken a small incision.
Yeah. We could have extended further. It's only a small incision.
Yeah.
If we are resecting, we'd have extended further.
but only saying you are seeing only single mets or multiple mets in the both lobes or liver.
No, this is it's more in the left side, more on the left side. It's both in segment 4 and left lateral segment. Right side doesn't seem to be this thing, and it's not a direct extension. It's definitely a metastatic disease.
But there is no
Sometimes you can
ascites
have
or
direct extension into the left lateral lobe. If that is the case, then we could have resected that part of that segment of the liver. We could have resected N block along with the tumor. But this is not direct extension. It is the metastasis itself.
but there is no mets or ascites you have seen. I mean peritoneal deposits are
There are no peritoneal deposits. Yes, there are no peritoneal deposits, and there is a slight the mild ascites is there, but that part mild ascites is not. We don't take it as that significant because that can be even nutrition also sometimes. So
since the lesion is in
that
the
part could
lesser
have been.
curvature and the body of the stomach. I think there is no vomiting history.
Yeah, there is no vomiting. There is no role for any like palliative GG or anything in this case.
Probably pre-op PET CT would have given some clue on this case.
Yeah, pre-op PET CT would have given.
So do
So
you
basically, diagnostic lab, that's what very important because we get these such surprises in almost 30% of the cases where you feel that all your imaging is normal and you go for resection and preoperatively do on-table diagnostic lab and you find about 30% of the cases, they have some peritoneal deposits like small deposits. But this is a big deposit which has been
Okay.
missed
So
on imaging.
having taken this as already a systemic disease, there is no role for radical surgery or even palliative resection, as there is nothing to palliate here even in this case.
Yes, at present there is nothing.
I think we need to move ahead. Let us get back to GEM and continue the discussion there. And Dr. Palanivelu has done quite a significant move from where we left, lymphadenectomy. So you can see, yes, sir, you are back with you.
You would have seen the video, and we are continuing the lymphadenectomy. You can see the common hepatic artery here, and
Yes.
and you can see the hepatic artery and GDA, and even we dissected the lymph nodal tissues. You can appreciate portal vein under these, and they are also cleared, and we proceed lateral to medial towards the celiac axis. Now we can appreciate there. I am depressing the common hepatic artery, take all the lymphatic tissues here. And clearance is better here now, keeping the traction in the stomach. If you cut it, it goes down, then it's a problem. Now you can appreciate there. And left gastric vein is here, that can be clipped later. And so now you can see there we go down, taking it. My left hand is pressing the common hepatic artery, and we take these soft tissues. One extra instrument you can place it to anyone, juniors particularly, and they can give the instrument to hold depress the common hepatic artery. Then two-hand dissection is better. Now I'm holding with my left hand and continuing. Now, see now we are towards the celiac axis, that is the cranial to the left gastric artery. And now you can appreciate the left side, this is splenic artery and this celiac axis. There are fatty tissues, we take it down. And if the left gastric vein is there, put one clip over the vein, continuing it. And most often vein always crosses the common hepatic artery, rarely goes behind it, the other side of it, posterior. and that goes joining the portal vein and should not be bleed. Very difficult to control later. Now see, we are clearing the tissues along the celiac axis, common splenic artery, and here common hepatic artery. Now you can see there, we again going taking all the tissues. You can appreciate the pancreas is free. And here again, when you do it and carefully doing it posteriorly, should not injure the vein. Vein sometimes will be more superficial. Now you can appreciate I'm stripping it and clean it. It is a in block completely that one. That way, this energy source is good, and very carefully using it, thermal injury to the pancreas is totally prevented. Now, see again, that stripping goes up to the hilum of the spleen. Then finally, we clear the nodes at the hilum of the spleen, and that is T10. That also can be done. See, you can appreciate because of magnification, the plane is very easily identified. You can appreciate the splenic artery is going down. And when you do it, strip down these from pancreas down to inferior border, and that is a layer, nothing but the anterior layer of the mesocolon, so that will be taken off completely. Now we come back again to celiac axis, and here post-gastric artery can be identified that needs to be clipped and divided if it comes. Now we'll go to the left gastric artery, and some instrument must depress the pancreas and this way like this. So then the visibility is better. Now see, you can appreciate left gastric artery is clearly visualized, and this clearance is very important. To the left of this is splenic left gastric artery, and now we make a dissection between both sides of the left gastric artery. This is a bipolar instrument, which is a nice way dissecting it. Any bleeder also can be just coagulated. Now you can appreciate left cruise that side, or anterior cruciate arcuate ligament. Now this is the left side. Now we can appreciate, this is very important to identify the plane there, and to see, we can celiac axis is very visible now that side. In stomach, as you all discussing, I could listen to the talk and about the importance of lymphadenectomy. And yes, otherwise survival cannot be prolonged. Clearance is very important. Now left side of celiac axis, right side of celiac axis.
It's a nice instrument, sir. Bipolar. It is being used
That's
as a
good.
dissector also. It's a strong blades,
dissects and
unlike.
also coagulates.
Correct.
Nice.
And you can see the retraction of the stomach upwards, and gradually the assistant is going on lifting it. So that will give a good counter traction.
Yeah, exposure is the most important in here. And robotic, what happens, the instruments are restrict life, so it bends down, on even with the hook, enough you can dissect well, because here this instrument rigid, that's a port placement also very important and should have. See now again, and gastric lymphadenectomy, Japanese, some of the surgeons doing it standing on the right side of the patient, and we are accustomed to do it standing between the leg, and it is all surgeons comfort making it. Now you see that tissues we are taking off to the left of this left gastric artery. Now you can see the splenic artery vein. At this level, one must be careful. Adrenal will be very close posteriorly. Should not go and injure. No need for it. Now, so left gastric artery is almost skeletonized, and see that side one small vein, it is there, and
Big screen.
I now request Dr. Balakrishna sir, Dr. Madhubi S. sir, Dr. Lokesh sir, Dr. R.A. Shastri sir, and
Now
Dr.
we put
Jaswant
the
sir.
clip. One can use hemolog first clip, then
Okay,
go
thank
to
you. Thank you.
yeah.
Thank you.
Now we doubly clipping it left gastric artery, and one clip towards the side of the specimen when dividing it with scissor. And don't use energy source. Close to the clip, it is like a clip will become loose. Huh? Now we divide the lesser momentum. We reach the hiatus. Huh? Now you can appreciate there that is the right cruise, and we go through the white line taking down. And particularly if it is a OG junction growth or it is a proximal sphincter growth bigger, then that area, this area must be dissected first to see whether resectable or not. Very important. And now that is the left cruise, and you can see arcuate and cruciate. Then go to the left side. And here again, that plane is very important, and you can see the phrenic vessels going up. And if it is that need not be divided, but if by divided also nothing will happen, but you can preserve it. Now, because the plane is in front of the phrenic vessels, now you can see the fundus, and when we go, we will be reaching the spleen. Not injure the spleen here. See, now appreciate the spleen. That tissues must be. Now we taking the esophageal membrane from the left cruise. See, now you can appreciate that all the tissues has been taking towards the left side most often. And now we are going towards the left side. And see, still greater momentum not touched. Generally, initially, we would have seen many times. Greater momentum is we take it first. This is a tendency for many surgeons. Now you can appreciate that that layer can be stripped easily from the mesocolon. This approach. Now see my left hand pushing this. And here when we injure the posterior layer and the duodenojejunal junction will come, and there must be careful not to go more posterior. And you can appreciate that pancreas is lobulated like, now strip down, go towards the now body, we are almost reached this tail. This is like we are opening the two plane of tissues. When we do this, the clearance will be perfect, maximum. The camera is coming from umbilicus, 30-degree scope, that is easily visualizes the tissues. Now that tissues has been taken from skeletalizing the splenic artery, and still I think we have not divided the posterior gastric artery, and will be coming here. Traction, changing the retraction of the instrument. Now we can appreciate the post-gastric artery. Because we divided the duodenum and taken the stomach to the left side, the visibility is so good. That's why we divide in the beginning. Only in advanced lesions, resectable tissue was assessed before proceeding it. Now, this vessel skeletalized, and we are going to dividing it. And ligasural harmonic is good enough to divide this vein artery, and beginners can put one clip and take it out safer. By manipulating it, it will not bleed. Harmonic is up to 5 millimeter very easily can control. Now you can see there, again we take down the tissues up to splenic vein. Even you rotate the artery to see the splenic vein to take the entire tissues up. This is upper pole of the spleen, closer to that we are there, and now you can see that fundus is visible, seen that other side. and that small tissues we have to take it off. Sometimes a small branch along with the posterior gastric artery supplies the spleen may be getting injured. That segment may become ischemic, but that is not an issue, it can be done. Now you can see we are almost reached this spleen. That part upper attachment of the short gastric vessels to the spleen vessel as well as the omentum. Now you can appreciate there, because of camera system is cam from the right this side, we can make it 30-degree, allows completely doing it this way. And this vessel is most often bleeds when we even anterior dissection or posterior, and that attachment any vessel not to avulse from the spleen. Okay. Now we can see this can be stripped. You can appreciate the splenic artery sometimes in branches before. Now you can see and vein is appearing here, which was posterior. Now it is coming seen. So now we should tilt the table on the left side a little more, then go and take down. Starts a dissection at the left side of the gastrocolic omentum, that is closer to the splenic flexure. And there that we can open it, enter the plane between the gastrocolic and the mesocolon. Now we can see, pardon?
Palani, good morning. Shastri here.
Yes, Sastri, yeah.
Excellent demonstration as always. So beautiful, posterior to the stomach. Can you just explain again how keeping the greater omental attachment till the end helped in the posterior dissection? That is not very clear. How does it hamper if you divided the gastric, greater omentum from the colon before itself?
Yeah. And this is Sastri, this end block, that means gastrectomy, omentectomy, and the lesser sac excision.
Yeah.
And this is two way we can approach. One is from the right side, and right side is where that pylorus and the duodenum, and there no lesser sac. We go in between the plane of this sac, then the plane of the posterior sac. So you could have seen, and I think initially you saw or not, and that's why I control the gastrocolic artery vein. Now you can see same way the other side have come this way. I almost done from right side. Now you can see I'm going between the mesocolon anterior layer and the gastrocolic omentum. That means I'll be going between the two layers of this layer approaching the T10, the hilum of the spleen. And see, you can see there the two layers. Spleen pancreas will come between the tail, two layers. One layer will go posterior, another layer will anterior. And there we very much little careful must be there, otherwise the left gastrocolic artery and vein may get injured. Now you can see that is one layer we divide. And retraction must be good, otherwise that layer very difficult. Now you can see here I'm taking it to the right side. And now see here, now you can see the pancreas and see their layer. Now you can appreciate the artery. Here, when we open the tissue plane two layers and we take all the nodal tissue, that is splenic vein, careful. And any nodal positive nodes beforehand shown by CT or MRI, then we given a chemotherapy taking up. And even the regression nodes sometimes create more of fibrosis, that dissection in this plane is very difficult. And many times we get a concern and we don't know whether it is a fibrous tissue or nodal persistence. And sometimes whatever you do, PET scan also may not be clear. So we have to plan for splenectomy if case necessary. Now you can see the pulsating splenic artery, and this side is a vein.
The other question is it always necessary to dissect out the splenic vein? Splenic artery is understandable for the lymph nodes. When you do not have demonstrated lymph nodes in the splenic hilum, is it
Yeah.
necessary to go to this depth?
Yeah, it is. We don't, splenectomy is not recommended unless
No,
there.
not splenectomy. No splenectomy. Only
Yeah,
the, I'm talking of only the clearing the splenic artery and not the
yeah,
vein.
yeah. If you, this clearance is very important. Artery as well as vein, both are important, because that once the nodal tissues at the hilum of the spleen and lying at exactly the vessels, so both vessels must be skeletonized. And carefully done, it can be done well, because magnification helps you. Now you can see I'm taking the vessels from the splenic artery and here, and if necessary put one clip and to the left gastrocolic vein and artery, that is very important. And a smaller ischemic portion we can appreciate, it will be there. But injuring one of these vessels, splenic artery, then you have to do splenectomy. Even an injury the vein alone, also we have to do splenectomy. That is. Now both sides. Now we can see it is divided. It completes it, and some more clearance we can do it after taking down the short gastric vessels. This vessels always sometimes slips bleeding. That's why I recommend to put a clip and divide, or take a bipolar. That vessel is good. So bipolar sealing this before division better. And particularly CS stomach, if it is a growth in the right greater curvature or body, this clearance is very important. Hilum of the spleen. Oh, see, I got it. The retraction is left lobe is must be good, and here bipolar is the better, and we let us see. No, should not become a tension. This, in case if you don't see, put a gas piece over it, press it for a few short while, then finally, slowly, you can release that. Then put a clip, and while bleeding itself, very difficult. That vessel we wanted to avoid, and see, you can see ischemia of the upper pole of the spleen. But generally, it takes up, no problem. And now with the irrigate and take it, see. Now that segment from the hiatus we released, only thing, some attachment peritoneum is there anteriorly. Now you can see the left cruise is visible, left diaphragm is seen, and this side is clear. Now you can only thing is great momentum attachment is completely is there. Any question here? Now wanted to.
Yeah, the left lobe you have not mobilized at all. Left lobe of the liver,
Uh,
that is generally done when you do a dissection at the hiatus.
yeah,
So
yeah,
you've gone totally posterior. It's totally acceptable. It's very clear, absolutely clear.
yeah.
But in open surgery, when you go from anterior, you always
Yeah.
release.
Now
Yes,
you can see I'm taking down the remaining attachment at the left cruise.
yes.
And we divide the left and the anterior and posterior vagus now also, but we little more dissect into the O junction is not involved. So, but still we need a segment for anastomosis and a staple application or this we need. We dissect it, but not to injure the mediastinal pleura. That is the left vagus now. Now you can see we have a good segment of this. This we'll take a stay. Sometimes this is like a spring, coils like it will retract into the mediastinum, and while putting a stapler or suturing, we need some handling, and that is a stay which will help. And it should not go through and through. If you use a sill, it should not go to complete vessels. And if you use a PDS, okay. But one can use PDS, but during suturing, difficult to differentiate. That's why I'm showing. So now the other left side also similar way. And now this one.
Yeah, you're putting those stay sutures after clearing the lower third of the esophagus. Do you
Yeah,
think by pulling it and sort of fixing it to the crura will stabilize it further for your
No,
further stomach?
if you don't dissect from the crura, it will hold. But once you release peroneoesophageal membrane completely and defect, it will retract. And better to keep stay that's not going to make it. Now you decide, I'm 2 centimeters, we'll keep it and we'll go. And if
Only
voltage
we'll
your
just come back. We have
more,
the other table also ready there. We'll just
uh,
go through that, the
which
history, and then we'll come back.
one? Okay, go ahead, please. Yeah.
Yeah, can we have the clinical profile of this patient?
Hello. Sir, we are starting with another case. He's a 40-year-old male patient. He presented with complaints of vomiting since 1 month, 2 to 3 episodes per day, non-bilious, occurs 30 minutes after consumption of food. And there is a history of loss of appetite since 1 month. He is alcoholic since 20 years. On examination, patient build is poor. And on CCT abdomen and pelvis, there is an heterogeneous circumferential pyloric wall thickening for a length of 6.3 centimeter and thickness of 2.1 centimeter, causing significant luminal narrowing with the distal passage of positive oral contrast noted. Few enlarged heterogeneous lymph nodes noted in the suprapyloric and infrapyloric region, largest measuring 1 into 1.6 centimeter in suprapyloric region. Yeah. You can see the CT. Yeah. And that this patient now we have taken for a diagnostic staging laparoscopy. And this is the upper GI endoscopy showing a 5.6 centimeter proliferative growth in the pylorus. Further negotiation was not possible. Histopathology shows adenocarcinoma.
We have amidst us the chairman of the National Surgical Gastro Update today, Dr. K.V. Ashok Kumar. I welcome him on behalf of the faculty and the delegates. Thank you, sir, for organizing this for successfully 21st time. And thank you for giving opportunity for people at Mysore to hold your own students who have come up with this meet. Thank you. And
Vijay sir, your mic on, sir.
Yeah, hi. Good morning, all of you. So it's a good luck that after 2 cases back to back of being inoperable, this looks very. So this you have heard the history for this patient. So in the latest CT, there was some doubt of there being a mild infiltration of the ascending colon, where there's a little lot of loss of fat plane. But here also it looks reasonably fine. So, and we have done a diagnostic laparoscopy because whatever said and done, diagnostic lab in gastric cancer has got an important role, and there is enough evidence for that one. It overscores the PET scan also. Yeah, it overscores the PET scan. Momentum, that's what I'm just. So we will just see. I'll just show you the clearly. So we decided to do a PET. The diagnostic laparoscopy first. We've gone. You can see this is the left lobe of the liver is clean.
Dr. Vijay,
Sir.
Dr. Ashok Kumar here.
Sir.
This is for the clarification of the students, most of the students and young budding surgeons.
Yes, sir.
Diagnostic laparoscopy, little bit, you have to elaborate on this issue.
Yeah, yes, sir.
Apart
So,
from, yeah.
So according to even the NCCN also, so there's one is plain contrast enhanced CT scan, then there is FDG PET scan. So both independently are inferior in identifying where there's a low diagnostic accuracy in identifying peritoneal disease. A PET scan combined with a CT scan has got better accuracy in terms of almost around 70 to 80% in identifying the distant staging. That is the M part. For T and N, definitely the contrast enhanced CT scan is superior to the PET scan alone. So that is why PET scan with CT if at all is the order of the day. But otherwise a contrast enhanced CT scan. But to identify omental and peritoneal mets, diagnostic laparoscopy has been shown to be more accurate for almost around 12 to 15% more than PET scan. So I think that even if we feel that it was perfectly operable pre-operatively, yes, sir. Yeah, yeah, I've seen that. That's clear. Mass is there. That was
Dr.
palpable.
Vijay,
Yes, sir. So that is why although the CT showed this is tumor, sir, stomach. No, under this. So once again, I'll just show them.
routinely
So
do
this is
PET
how we
scan?
do a diagnostic laparoscopy. We enter, see the left lobe of the liver, the left hemidiaphragm, left
One
subdiaphragm.
second, Dr. Vijay,
Sir, sir.
before that.
Sure, sir.
Anything else? What is your take on lavage?
Yeah, lavage has definitely got a role, but that is provided we have a I didn't elaborate on that because we don't have a frozen here. So ideally, if there is this much of ascites, say 100 and 200 ml of ascites, even otherwise also, in the absence of ascites also, there is enough evidence to show that if we do a DPL, that diagnostic peritoneal lavage, before we proceed for a radical resection, it definitely has got a role.
That's what
Yeah,
exactly
that's right.
I want you to convey to
Yes,
the
sir.
audience.
Yeah.
There is a role of diagnostic peritoneal lavage.
Yeah, we use anywhere between 2 to 5 liters of
Exactly.
saline
Yes.
On all 4 quadrants and also
Yes.
the abdomen.
Yes.
Then take all of that and send the whole lot of 2 to 5 liters what you have done to the
Exactly.
pathology and wait for some time, make your initial assessment by that time.
That
And,
sedimentation has to be looked
yeah,
for malignant cells.
that's definitely. And this patient, if you see the pre-op imaging and evaluation, the scope was able to pass into the D1 and contrast also had passed into the stomach. So there is no real reason for us to do a resection in terms of palliation. So however, this looks free here. This is so I was telling about the left lobe of the liver, the left subdiaphragmatic area. They see the falciform on the left side, then see the right side of the right lobe of the liver, the right under diaphragm, then the right layer of the falciform, then see the area of concern proper, the stomach and this area, and then the peritoneum. Yes, sir, I'll show. And then we see the pelvis.
Dr. Vijay,
There are
did
no
you
notes
see-
in the
did you
pelvis.
saw- Dr.
Mesentery is
Vijay,
fine.
Dr. Vijay, did you saw the transverse mesocolon?
Yes, sir, I'm just seeing that. So the peritoneum and looks fine. So now we'll come to little more specific area of seeing the omentum and the transverse colon. So this is omentum and Professor Ardnaroy sir is here. So this is a small area of concern if at all. And if you lift the left lobe of the liver, because it's a little bulky tumor, this area looks fine. This one.
There is some small nodule.
This is in the lesser omentum.
On the liver, do you see any nodule?
On the liver, no, sir.
No, not on the surface.
Not on the surface. The
Lift it up.
undersurface, there was small.
Yeah, undersurface.
This one. This one here. This one. This was what we thought. This one, small one. This is also doubtful. And this is 2 areas. Yeah, I'll try to see that. So definitely the colon looks free. This is one area of concern. This probably will come in the specimen. We are more concerned about this area.
Yeah, momentum is not a concern.
Momentum is not a concern, sir. Yeah. So can you hold this? And,
Tumor is liftable,
I'll
I
put
think
one
so.
more
Vijay?
port and move that. Come. I'll just put another 5 mm trocar and see the mobility of that area, whether it's in the lesser omentum or in the. Yeah.
Hi Vijay, Dr. Lokesh.
Hi, Lokesh.
Yeah.
Morning.
I think Dr. Palani sir is waiting. We'll come back you. In
Yeah,
just
sure,
5
sure.
minutes. Yeah.
We'll just see that area how it is, make an assessment.
Yeah.
And if it's operable, then we will go ahead with the surgery.
Hello.
Palani sir, yes sir. You can proceed, sir.
Yeah, now you can appreciate. I think you would have seen I've shown the country video now only I start, and I'm stripping completely the mesocolon here. Now only the great momentum out at the end. I'm coming back. Now you can see you are taking from the transverse colon, and entire great momentum we displace towards cranially. Then we go around. And when you come from the left side, and you all appreciate the colon is like a splenic flexure higher, and the right side of the colon is lower. So when you come above down, very easily you can see visibly like this. See the mesocolon strip also we do. Completely we take it down. That's why we call end block. We go towards the right side. And the right side already we have dissected the transverse colon from gastrocolic. It has to reach that segment.
Hello, sir. This is Dr. Lokesh from Mysore.
Yeah.
There are many people who advises like the stripping of this anterior mesocolon layer is not required. What's your take on this, sir?
Yeah, this is it is not. It is initially we were doing it. Now the study says that is not a must. But any growth posterior wall, and if it is clearing the lesser momentum, excision is partly to be done. When we do that, and this is only a small extra, great momentum you have to remove, and posterior lesser sac has to be taken. So this one layer is not going to change it unless we take it out. And if we want to do total clearance posterior wall gastric carcinoma, that serosine wall, this becomes a part. Otherwise, generally not necessary. Now you can see here, this is small attachment remaining. And so this is a technique as shown, and to do it, how to do it technically. And Europe, Korea, there is one group say they go straight away making it this complete, but they open the lesser sac and they strip out. But this is one mesocolon now. Recent trend is such a chemotherapy, all other adjuvant therapy, all has come. That is not compulsory, but I shown the technique how, and now see this is finally almost complete. That is one reason also now local recurrence almost very rarely we come across. Now, so you can appreciate this is reaching the last bit of segment.
One minute, sir. We'll go to other OT and then we'll come back.
Yeah.
Dr. Vijay, I think.
Now it is the resection is complete.
Lokesh, can you hear me?
Yeah. You can proceed,
So the one in the lesser sac we saw, it's on the lesser omentum, a small nodule in the lesser omentum. That is also going to come within the resectable specimen. Okay. So we plan to go ahead with the surgery, and I've requested Ardhanari sir to go ahead with the surgery because the first case was inoperable. Yeah? So we'd want to see him operate.
Okay. Thank you.
Okay, over to sir.
Dr. Palnival, sir, you can proceed, sir.
Yeah. Now I will show that. See, now you can appreciate here, and after removal of this entire, and the 3 minutes we come. Now we can see here, it is going to be released. And we make this, I'll show you two types of reconstruction. And this particular case, we made a mini incision and no, intracorporeal. And I'll show a small video, 2 minutes of extracorporeal pouch reconstruction. Then I'll go laparoscopic, this particular case.
Do you routinely use the pouch in all the total gastrectomies?
Not total, majority of the cases we do it.
Even
We are comparing this and with this one, and studies also shows after a year, nutritional status better with the pouch, and laparoscopic we can reconstruct it. It looks good. I am doing it, but generally it is people don't know. I don't know what is your opinion.
No, sir. Usually the practice is like the malignancy is usually majority of the patients they get like a direct intersite anastomosis. In the benign patients, usually we do a practice of the corrosive patients.
Benign is a different. Benign is anything we can, but malignancy, if you do a D2 radical, see this is a extracorporeal pouch. It is needs a 3 stapling. You put it 15 centimeters. And a simple technique just to show them how to do it. And this whole video, this is not this particular case. And
Sir, Dr. Palnivelu,
yes, sir.
Dr. Ashok Kumar here.
Mm.
We regularly, for a total gastrectomy, we regularly do this pouch, sir. It doesn't take much time. It's only a question of using a couple of staplers more. We
Yeah.
regularly do a pouch, and as you said, nutritionally over a period of time, it is better than comparatively.
But their point is a concern. No single study still say that it is a part essential to do it. Just,
That's
first,
correct.
only a
That note is
model
good.
concerned.
That note is good when there is a slight advantage over straight away esophageal. Just do a
And
pouch.
10, 15, 20 years before, the survival rate in gastric cancer was very poor. That is fine. But now we are, Japanese shown, Korean shown, success rate is so good. And this also becomes, majority of the cases, they live longer and very important. This small technique just want to impress it, and I will show. But I will show laparoscopic. I don't do open this pouch. That's why I thought it's better to show it. Long time back. Actually, in fact, it was done in a live workshop.
No, I don't do laparoscopically. I am not that proficient like Palnivelu. I was talking only about open surgery. And I work in a government medical college hospital, and the supply of staplers is no issue at all. We use left, right, and center. I don't mean
Sure.
everything can
That is
happen
not,
in private sectors. Definitely, money matters.
See, now we reconstruct this. I think what we'll do, and side to side make it. It is all, see the hand sewn again, cost reducing those days. And private also difficult, show people coming from villages, we have to be more, and they are paying from their pocket. So otherwise this stapler would have been easier. No, I will show laparoscopic now.
Sir, can you explain the advantages of the making the pouch from the
Advantage?
the firing the stapler from the back side rather than from the tip end side?
Now I'll come that laparoscopic. And
No, sir, the pouch which you have, the staplers which you have fired from the back side, the J of the open side of the J, rather than the apex of the J.
laparoscopic much easier than this. Compared to open, laparoscopy looks easier. If suturing is known, it is better. I made even entry for stapler. So now I placing this. See the specimen. I removed this incision. It is 5 centimeters only. See, look at how small. Through which I remove the specimen, I reconstruct it. So this is exactly like people. If you say it is a total laparoscopy, they will believe. No scar also visible. I made it subacute. Now you look at this as same pouch, put it inside. This is hand sewn after stapling. See, I already made enterotomy through which we stapler, we insert, and the stay also helps you to bring it now. And BUG or rails tube, keep it entry inside so that we can, while pushing it, be careful that jaw should not make a punctured in the posterior. It happens, couple of cases mine, we have to suture back, and because that easily will pierce through. Small bowel is not that, Now this is a reconstruction, lap assisted suturing and single layer, and using 2-0 PDS, starts from left end to going to the right side. Continue suturing.
Sir, is it always side to side, or can it be end to side also with anvil? And
Side to side, why I'm making it, vertical one stapling and make side to side tension free. Subsequently, anterior doing it at the same. So stricture is unlikely in this type of one linear, then comes anterior suturing. Even anterior, if you use stapling also across, it makes now lumen is not a circular lumen, it is a oblique posteriorly. I don't find any of my cases tension stricture. Second thing is also, and this particular technique leak proof. I don't see any leak. And that's why one stapler side to side, then you vertical. This is also, the Koreans also recommend the same, no?
Okay, sir.
It is created tension free. Now you see, and rails tube goes across. It has to go beyond the end of the pouch, so that you can start feeding the patient in a few hours time. See, it goes beyond, and initially 3-4 days feeding purpose. Second, later we do gastrography, anastomosis fine. Third, fourth day, take out this and patient given oral. By the time the pouch also functions well. Now tightening it, very important is, and if it is full not there over, we have to second layer, we have to come, and approximate tightly single layer, it is good enough.
For this tightening avoidance, can we use this braided suture, sir?
Yes. Now it was not available that time.
No, just asking, can we use it for
Now it
anastomosis?
is V-lock. V-lock is better, and we have a 2-0, we have a 3-0 now. According to the bowel thickness, one can choose. And this particular situation, 2-0 is ideal, and 30 centimeters when you use it, it keeps the tension. More important is avoiding leak. And now V-lock also cost has come down, and a few companies making it now. It is.
Sir, is there any minimum length of this pouch?
Pouch 15 centimeters, 3 cartridges, 6 centimeters, cartridge we use 3. 15 centimeters is a pouch. Okay, now I will show that laparoscopic pouch, and hiatus has to be repaired. One stitch has to be taken to the crura, and it should not retract and inside this wheel just. I will go that. This week I did 2 total hysterectomy, all pouch only. And patients also, when I say that I'm creating pouch, you can have a good quantity of food, they are very happy, accepting it. And this is endoflex, we can divide it. And now you can see, and this is while taking pouch, and we take a tension free. Wide hiatus is very important. I extended the hiatus anteriorly, so wide opening in case the stapler has to go inside the mediastinum has to. Now see, I am making a enterotomy, and here also rails tube is inside. And generally, nowadays I take a BUG very easily, can create and can be see. So one jaw goes to this here, the another jaw into this, similar one but the previously. And this hiatus opening, widening more important. If it a stapler can go very easily. Now we'll fire up, and so now, and this also suturing, and across one stapler, you can epigastric trocar, you can make it 12 mm. Take 2-3 stay suture, and across a stapler can be used like a esophagus intrathoracic anastomosis. And now I'll go for pouch, and this also pouch, this staple. Now you can say there's I use a stay sutures, and I putting it across and taking out. This Hong technique, this Korean, he does this way. And their one advantage is suturing edema will not be there if you do a stapling. And this is goes from down, it is not a good. Always go epigastric across. That is the best thing. They tried it is not there. So you can see, appreciate here, and over and suture one can. Hey, pouch creation.
The other OT is starting. I think we'll just come back.
You forget that. I will take it ready. I will come back.
Dr. Ardhane, sir, I think you can start.
Getting delayed, no?
Ramesh sir? Ramesh sir, your mic,
Yeah,
sir.
okay. So this is the growth you can see It's fairly a large growth, and I think this is where they said the colon was ideal. It doesn't seem to be ideal, it seems to be free. There seems to be a lot of stomach, so I think we can get away with a subtotal gastrectomy. So what I'm going to do is now that the first thing I'm going to do is, you hold this please. Now you can relax this for some time. I'm going to take the greater momentum off from the transverse colon, and I will do since there are serosal deposits, I will be removing the lesser sac, which means I am doing an omental bursectomy. So I'll go between the third and fourth layers and remove the peritoneum on top of the pancreas.
Ramesh, Ashok Kumar here. Good morning.
Yeah. Hello. I can't. Volume, please. I can't hear it.
Dr. Ashok Kumar here. Ramesh.
Yeah, Ashok. Tell me.
Good morning, I said.
Good morning. Good morning.
Welcome to Mysore Medical College.
Ah.
And the other word, it is called as third layer of the great momentum, right?
Yeah.
For the benefit of postgraduate students, I just made this statement.
Yeah, the greater momentum, but I'm going to remove it with the.
That's what third layer.
Third layer. So
exactly.
The omental bursa.
Bursa, correct.
Now, if you look at this, can you see from the camera? Hello?
Yes, Ramesh.
Yeah, you see this forceps? You can see the vessel is exposed here.
Yes, sir.
See this vessel. So, when the vessel is exposed, you remove the third layer. The vessels lie between the third and fourth layer. So, that's one way of knowing that you removed the fourth layer, okay? The third layer, sorry. Now you can see very clearly the second part and the first part of the duodenum. See, that's the second part. Can you see that?
No, sir, the camera is that side.
Camera, please. Can you bring the camera in?
Yeah, sir. Now
Which
it's better.
camera?
Yeah.
This is the duodenum. Can you see that?
Yes, sir.
This is the first part of duodenum. Okay, this is second part of duodenum, the vertical part. Okay?
Yeah, we are seeing.
Yeah, so I am removing the. From here, I am removing the third part and going up.
Sir, as you are both open and laparoscopic surgeon, you do efficiently both the lap D2 and the open.
Yeah.
So for the benefit of the new surgeons or the young surgeons like us,
Yeah.
how do you decide when you are going to do a lap and open?
See, sorry, just let me. I'll come to you. Yes. See, nowadays I do very few gastrectomies. They're all done by my junior consultant or by my DNB GI surgery postgraduates.
Yes, sir.
So when I do, if they want me to do a laparoscopy and show them, I do.
Okay, sir.
But the problem with laparoscopic gastrectomy is not the technique, it is the expense. You need all those staplers. You know?
Lap staplers.
Lap staplers. You will see Palni is now using the staplers. No, you saw him using?
Yes, sir. Yeah.
You will soon see him. He will be firing multiple staplers. It will take 4 or 5 staplers. So the cost becomes too much for our patients. I get generally a poorer class of patients than what many places. And since we are not a government hospital, the staplers don't come free.
Oh, yeah. Okay, sir.
So lap gastrectomy, I demonstrate when there's an insurance patient, when there is a patient who is rich and can afford the staplers and wants lap gas, then I demonstrate.
Ultimately, it's affordability, right, sir? Ultimately, it's affordability.
Yes, to a large extent, it's affordability.
Harmonic, I think the settings, should you increase it a little bit?
No, this is 3 and 5. That's all I can keep it. No more settings up there.
Okay.
A small bleeder here. I'll just take care of that. Yeah. Bipolar. Pedal.
Sir, Dr. Palni is waiting to show some.
Yeah, you
pose
can
here.
move there
I'll-
now.
I'll come back, sir. Dr. Palni, sir, I think you can.
Yeah. Now I'll show a different anastomotic technique and the pouch. And see here that it has been done, mobilized completely. We are going to divide this. This is up to OG junction is there, so we take down. That is which I am holding is the vagus now, releasing it. That tissue must be removed. And now we use a linear cutter. This is a purple, and depending on the company, it changes. And if you want to do any anastomosis within the hiatus, particularly when in case of involvement of OG junction, and it has to be widened the hiatus, and circular stapler may be better. See, now I'm making a little more widening. In case necessary, the right and left screws also will be retracted either side. Now you can see inside, we dissect the lower end esophagus.
Dr. Palni, sir.
Yeah.
Any experience of side to side esophagojejunostomy using linear staplers and its advantages?
Which esophagojejunostomy.
Esophagojejunostomy.
Yeah. Now, that's why it showed a linear. Now I'm showing a circular.
Yes.
Because within the mediastinum you can do, this is easier. I'm not different technique I'm showing for the PG purpose. Now see, this is a small bowl I'm taking up.
Advantage, sir, between linear and circular.
Pardon, Ashok?
Advantage between linear and circular stapling.
Advantages, and if you go through mediastinum, do wider the hiatus divide, then you can do. Otherwise, lower level, yes, linear staple is better, and slightly higher circular. Circular only disadvantage is a stricture possible.
Exactly, that's the major issue. Sir.
Now I'm going to show circular, and of course, one must know. So some patients, depending on this, we'll see. Now see, we have to take a tension-free jejunal loop like this. We have to assess it, and then see, we have to keep a loop of length for the stapler pouch. We have to do it, and we divide this. White cartridge is preferred for a small bowel, and this cotton tape is for measuring the pouch. 15 centimeters as already discussed. And 3 cartridges will come for a 15 size. Each one, though we fire 6 centimeters cartridge, we get it only functionally 5 centimeters. Now we can create a window through this small bowel entry. Then we make it a division here. Now this is for circular stapler to go. We make it opening in the jejunum. Now you can see bowel is also keeping it, and usually we pass the Orville, and through this we bring it out. We'll take it down. So you can see it reaches the lower end, and we have to cut the thread. During this time, what the anesthetist, they will always release the cuff, then bring it down. Otherwise, that it will be difficult, hold it. Now you can see it is reaching the lower end. Now we make incision just to go the circular stapler head. Then we keep a plastic tube and through which the specimen will be taken out and to prevent the wound infection. Now see, introduce the circular. And bariatric surgeons frequently use, they are very happy about this way doing it. Now we pass through this and we are going to dock it to the here. That's why the hiatus must be widened to the center to go inside. Now approximating here. Now it is, we'll be seeing the green color as usual and approximation. Then keep it for a minute.
What size circular stapler are you using, Palni?
This is 25.
Is it enough?
25 is okay. That is one approximate. More than that, it is not necessary.
The
Unless
esophagus will not allow more than a bigger size than 25, right?
yeah, bigger size if you use, esophagus must be dilated.
That's what
And-
esophageal lumen will not permit. Bigger size, esophageal lumen will not permit bigger than 25 size.
Yeah.
That is the problem. The stricture formation is incidence is very high.
Yeah. And now see that end will be staple at dividing it, and we pass the rail tube also as usual. And I have a pouch divided already for a pouch reconstruction. Now we can separate. Now see, this is a bowel. Make it 2-3 stage switches between these two segments is very important. Now we are opening it, and similarly we enterotomy will make it in the bowel. So stay will be exactly helpful. Otherwise, blindly doing it, sometimes one may be a little more or less. Now we introduce the linear stapler. These all are white cartridges, and yeah. Now you can see here, and which mesentery should not come in between the staple line. That must be very careful. And pardon? Yes,
Dr. Ardhanari is going to finish. One minute we will go to that theater and come back to you.
Yeah, please go ahead. Yeah.
Moses?
Ramesh sir?
Yeah.
I'll be back with you, sir.
Yeah. Who is there?
We are all here, Ramesh.
Okay. I want to show you. I just opened the Lesser's stack.
We are seeing.
And you can see the growth is infiltrating the pancreas. See, that's the pancreas. See that?
Yeah,
We are seeing it, sir.
That's the pancreas. That's
sir.
the,
Multiple deposits.
yeah, and it's possibly the
Puckering also.
middle colic. And you can see that the deposits keep going there. See that?
Yes, sir.
Seeing.
There are a lot of deposits.
Lot of deposits on then and then there are tumor nodules along the lesser curve here, there. So this is an extensive tumor. I don't think it's worth attempting any resection.
Not at all.
Yes, sir.
Not at all.
Definitely.
And if we want, we can do a GJ, which I can leave it into the hands of our
Sir,
surgeons.
when do you
here.
advise the shaving from the pancreatic capsule and you
Very rarely, just a little bit of adherence on the head. Yes, I would advise shaving, but not when it is adherent like this.
Not only adherent, there are multiple
lot of,
nodules all
Yeah,
around.
all over. I don't think this is can be shaved or it
Yes.
should be shaved.
Correct, sir.
This should not be taken out. This is
becomes a grossly
forcing a
organ.
resection which is not necessary.
Yes, sir.
Exactly.
So what I'm going to do is that you see lots of stomach is there. There is some evidence of obstruction because the stomach is dilated.
Yes, definitely
they-
dilatation. Yes.
So they can do a GJ here.
I
do
think
a
we are
GJ
seeing
here
all
with
the
a stapler
varieties of
and
surgeries for CS stomach.
which one?
All the possibilities of CS stomach which we
Yeah.
are seeing today, sir.
Yeah. See, this is one of the problems with CS stomach, that you think it will be this thing, but it will be completely
Metastatic. Yeah.
metastatic. Even along the aorta, there are nodes. So I don't think that this is at all resectable curative.
Sir, Ramesh,
Yeah.
please tell for the sake of postgraduate students, GJ you are going to do which GJ and why?
One second.
They will be interested.
What GJ?
You are going to do a GJ, no?
Yeah.
And which GJ and why?
We will do a loop GJ, like
Anterior, posterior,
anterior anticolic
anterior, anticolic, and the greater curvature or anterior.
on the greater
wall.
curvature.
Yes.
On the greater curvature, a horizontal GJ like this.
Exactly, sir.
Okay, so
Why not a posterior? But some PGs are asking why not posterior GJ?
you saw the bed is all infiltrated by tumor.
Exactly, sir.
So you take a bowel loop there, it may get infiltrated and the loop will be blocked. The whole object of you doing it will be gone. So
Yes,
I
sir.
think since there's less tumor anteriorly than posteriorly, I would go and do an anterior. So in CS stomach, I routinely don't do a posterior because it always has to be posterior means you have to open the lesser sac and then you have to go in. I don't like to bring it retrocolic in a palliative GJ. So I have to go anticolic but posterior. That means I have to open the lesser sac. But I don't want to do that in this case because there's so much of tumor. So I think we should do it on the anterior surface.
Sir, in benign condition, do you still advise only posterior or anterior?
Sir, in benign conditions, my GJ is a anticolic, posterior, juxtapyloric, horizontal gastrojejunostomy. So,
Sir, how can it be anticolic and posterior GJ,
yeah,
sir?
you open the lesser sac.
Then it will be posterior.
No.
Retrocolic.
No.
Retrocolic.
No. You don't need to go retrocolic. That's what I'm saying. You can go anticolic. No. See, I will open like
anticolic and open the
the same, and I do this here now. It will be retro. It is anticolic, but it is posterior GJ. No, if I do it here.
Okay, like that. But
Yeah.
I believe in retrocolic, posterior, gastrojejunostomy, short loop, no loop, no tension.
People believe in lots of things and
Yes,
they
sir.
can do. But the problem that you will face, which I've seen as an endoscopist over the years, is that those who do this, what happens is the stomach shrinks after some time. And the GJ is no longer in the lower part, it's in the higher part of the stomach and it has moved up posteriorly. It is no longer as dependent as it was.
Sir, I disagree. All stomachs will not constrict, sir. Retract.
Some stomachs
That
will.
is the stomach
So-
which you have operated on gastric outlet obstruction without proper preparation of the stomach washouts, etc.
So I do.
Those are the stomachs which will
So
shrink.
I don't care whether stomach is prepared, not prepared, because my anastomosis will be juxtapyloric. No.
Sir, you may not care, sir, but I do care. We all care, sir. Stomach
why?
has to be prepared.
Why?
So,
When-
see, this is what happens. The problem happens. The stomach has to shrink, sir.
Sir,
The stomach has to shrink. Otherwise, post
sir,
operatively it will shrink.
sir,
and
I
definitely it
am
becomes a narrowed
not.
lumen.
I am not asking you to do
Yes.
what I am doing. I am
Agreed.
telling you
Agreed,
what
agreed,
I do.
Agreed.
I am telling you what I do.
That's why exactly I am also asking. This one for a debate, no, sir.
Because-
the boys have to know. That's all what it is.
So it will delayed. Actually, my results will be better because no matter how it shrinks,
Yes.
because it is juxtapyloric, it will remain in the dependent position.
Yeah.
And it is posterior because that is a better dependent decision. This thing.
Correct.
It is anticolic because I don't like to go retrocolic with the short loop.
Fine, you are comfortable with that.
Yeah, I am comfortable with this.
Correct.
Yes.
Sir, with
And-
It's ultimately it suggests comfort.
Yeah, so I've been
And
doing this
yes.
for 40 years, and to do it laparoscopically is so easy. So even
Tell me that point.
Sir, I
Laparoscopically,
think
also
Dr.
agree.
Palani sir is waiting to
So-
finish his pouch.
So we are not going to
Or
do
No,
any
it's an
major
anterior GJ,
resection.
Anticolic, anterior GJ.
We'll do an anticolic anterior GJ,
Yes.
which the people
Greater
assisting me
curvature.
are capable of doing it. I don't have to do that. They will
Okay.
do it. And whether they do it hands-on or use a stapler, I leave it to them. In
Hello?
my unit, the
Open
MS
the-
final year PG, DNB final year PG in general surgery will wash up immediately to come and do the GJ because that is their chance.
Relieve the boss.
No, it is their chance to do a surgery.
Exactly.
Sir, with the advent of laparoscopy, anterior GJ becomes easy. So
Yeah, but I don't do it anterior. So even with laparoscopy, I do exactly the same. I open the lesser curve
Yeah,
and I
thanks, sir.
put it posterior and
Yeah.
bring it juxtapyloric, and it's a horizontal.
Thank you, sir.
GJ.
I think we'll
Even
proceed with
laparoscopic, same thing.
Dr. Palani sir is waiting to show
Yeah,
it.
hello. Hello.
Yes, sir. You can proceed.
Yeah. See, it's a second cartridge you can appreciate here. And the same entry, same using it for multiple cartridges to go till and fire from this. While taking out, should not pull it out so fast because mucosal laceration can bleed. So one more cartridges we can use it. And as you can appreciate, and so same trocar, and open the jars before introducing it and carefully.
And coffee and tea is being served right outside the hall. I request everyone to have it.
Yeah. Now we are closing the jaws, checking the mesentery, and firing it. To, and now it is after firing, we are going to take it out. And this linear cutter is so comfortable. Even an open pouch you want to create outside for ilioanal pouch, anastomosis ileal pouch, there also the same way these cartridges are very helpful. And then that entry we can be, see now this entry we can suture or we can put a stapler across and make it up. And across the transfer suturing is better. One stay this side, another stay that side, so it makes convenient suturing it. Or put a stay, few stay, then put a stapler across. Makes it. Yeah. Any question now? Kindly go ahead, yeah, please.
This pouch is like almost completely different from that open surgery.
Yeah,
pouch.
just showing a different way, different techniques. About now, almost no open. And, our almost all laparoscopic we create. And beginners, some people, if it is want to do it, they need not go complete laparoscopic struggle, taking longer time. That pouch we can reconstruct outside through specimen. But now we take a specimen through always phalangeal incision. So that's the reason that we don't do it pouch outside. So I think this is, you can appreciate here. And they technically maybe some issues, whether benefit or not. If you ask Western people, I don't think any Taiwan they do, or Koreans or Japanese, they don't do it. Their impression is that our diet pattern so much, I personally feel what Ashok also told, same thing. Now we are Ru and Y, we are completing it, and that jejunum, proximal jejunum, afferent loop, we take it to the front side, 30 to 20, 30 centimeters beyond the pouch and make it up. The measuring roughly. The right tube is passed so much for beading purpose. It's too longer. Yeah. Okay. And so we'll make enterotomy here. And the hook is a very ideal one to make it enterotomy. And it will cut. Very nice. Then we introduce one jaw into this jejunum and here.
The increase in the risk of leaks when you do so much of pouch and the so much of stapling as compared to the Roux-en-Y end-to-side esophagojejunostomy?
Yeah. Leak is also possible unless we reconstruct anastomosis very well. And we had one case of a leak, and that was a minute leak in the staple line. So that's why, suppose if a nutritionally patient is problem, or patient already taken chemotherapy, and then we are doing it, that particular situation, what we do, overrun the staple line is better. And that prevents the leak. And those days in the beginning, and staplers was not that good quality, and we had 2 rows of staple pin those days. So what we do, overrunning is always we do doing it. And now the companies making a very good cartridges, longer cartridges, 3 rows, and both white and blue or different thickness available. So that way it is, I think now and overrun is not necessary unless we think it is otherwise. No need for it now. And staple line, if you look at endoscopic, the edema almost nil, because that is very makes very much very comfort. That's the reason also one. And here vascularity we know exactly well, so no problem. But if esophagus, even in the gastric tube, if you go to reconstruction, then the tip of the stomach can go into gangrene in the vessels if it is a thrombosed. That's why handling of the vessels must be very careful and making it up. So now we come from above and we use a 2-0. And if your team is there, and if it is total gastrectomy and difficult cases taken, the reconstruction can be taken up by another team. They can go, can reconstruct so well and without fear of a leak. And tiring one should not compromise. That's why duodenal stump, if you do a gastrectomy, and those time and even whatever time material, you always overrun the stump. There the leak is once happened, it's a problem.
You are advising to overrun all the duodenal stump staplers?
Yes. Not every case. Staple line is good. Look at vascularity, no tension, then no need for it. Individualized case may be better.
Sir, very recently, there is an article which appeared in the name of journal I have forgotten. The name of that journal I have forgotten. Very recently, we read an article of duodenal stump closure. Overrunning is better than without overrunning. It prevents the leak rate. It is significant p-value significance test.
Yeah, that is hold goods for the whole previous staplers, 2 rows.
No, sir. The recent ones.
Yeah.
And they have described the type of stitch also that
yes, I agree. Overrunning is always, even colon anastomosis, overrun sutures is many recommends doing it to prevent. That's why I'm telling any particularly nutritional affected hemoglobin, some problem or this chemotherapy, then that particular patient is always doing it better, overrun. If overrun suture is always seromuscular, it's not going to the lumen compact. And also
exactly seromuscular, and it will be invaginating also.
Yeah. Yes. And it's when we overlap, it's also good for hemostasis. If edges are bleeding, can do it. Okay, Ashok, any question, any comment, all can make it, and we'll go for different procedure later.
Any questions, delegates? You people, you are silent spectators, so please participate. Trick of the trade, you have to get it from the experts. Feel free. Don't have any inhibitions. Please come forward, ask a couple of questions.
I'm very unhappy you are not called to Mysore to do surgery. Mysore is so lovable place, friends are there.
Sir, Vanga sir, you come tonight, we will have some chilled beer, and then tomorrow we will watch from AAG. நீங்க வர மாட்டீங்க சார், you are busy Coimbatore, Chennai.
Last time we came to Mysore and was taken to Swamiji's place, and we had a lunch there, very nice. After that, I could not make it up.
Big people will always have privilege, sir, to meet Swamijis and take blessings, have lunch.
Swamiji came to Coimbatore Gem Hospital once, and to see his friend.
Okay, that is the secret.
He also called me once to come. I am not finding time to go.
This is reciprocation.
Yeah.
Yes, sir.
And this is a divided end of the crura, must be repaired. Otherwise, and this segment will go inside and problem.
Herniation, to prevent herniation, that needs to be hitched.
This is non-absorbable, and how much difficult in open repairing this one, Ashok?
Yes, sir. Now, if the assistants are good, the wide retraction will be there. And because I am not proficient like you, we always do open and we stitch it up.
Open is visibility. This area is not that.
Correctly, sir. It will be visible, sir. That with good retractors and all, we
Yeah.
mobilize the left lobe of the liver, and we get a good open out there. Sir, about 20 years back, அதான பண்றது சார்.
Eh?
20 years back, பண்ணது எல்லாம் ஓப்பன் தான். அக்லேசியா ஆச்சு, இல்ல ஜி ஜங்ஷன் டியூமர்ஸ் எல்லாமே
Yeah.
ஓப்பன் தான்.
Now you
பண்ணிருக்கீங்க
can
இல்லையா?
see the gastroduodenal. Okay. Now we
Yes.
place the bag. The specimen will come through the financial incision. Okay. Ashok, what procedure you want to see now?
Sir, just
Okay, I'll show the gist. I'll show now.
yes, sir, yes, sir.
Two
Sir,
different
okay.
types of gist I'll show. One is
Yeah.
on the greater fundus, another is a lesser curvature.
Yes, and இப்போ ஒரு duodenal இருந்ததுன்னா காமிச்சுங்க, இல்லைன்னா விட்டுடுங்க.
Yeah, I'll.
Duodenal, yes, sir.
Sir, just enlighten us like regarding the D2 lymphadenectomy, the inclusion of the middle colic lymph nodes. Do you advise to remove the middle colic lymph nodes routinely, or only in the those cases where the middle colic lymph nodes are enlarged?
Fundus காமிச்சல அதானே? ஓகே விட்டுரு half an hour இருக்கா? சரி அங்கங்க ரன் பண்ணிக்கிறேன். Okay, Ashok.
His question is middle colic nodes. Our colleague has a question. Repeat the question.
Yeah, sir, this is Dr. Lokesh. So, the middle colic lymph nodes, do you routinely remove in D2 lymphadenectomies, or only in cases where it is enlarged?
Oh, asking me?
Yes, sir. Yes, sir. Yes.
Yeah, this is, you don't call it as a middle colic, and we call it as a right gastroeploic vein when formed the loop of Henle.
Yeah.
So the nodes in front of the middle colic artery and vein at the root of the inferior border of the neck of the pancreas.
Yes, sir.
So that node we clear. That is again issue now. One group believes it is not part of this and 14V, what we call. I think I always remove it, in particularly antral carcinoma and the pyloric involvement. And we take down, and it is extra 5-10 minutes to take it down. So that's why today morning I shown, I think you would have seen, coming from the right side, taking it, we can see, visualize the inferior border of the neck and the vein, for middle colic veins, and the junction of the middle epicloid. So I put a clip, divide the vein, clear these fatty tissues, then go, the entire pancreas will be free from the fatty tissues.
Okay,
I
sir.
always doing it.
Means like only the distal malignancies, I think it's better to clear off those kind of lymph nodes. Yes.
But there's some body of the growth or somewhere people say that is not necessary, but nobody says not to do, but
Yes,
it is
sir.
all choice and choice doing it.
Yeah. Thank you,
Technically it is feasible, and it gives one way of getting into the part 1 duodenum after taking the vein, and we go to right gastroeploic artery. That artery also can be taken, that it becomes much more better. They're very important.
So regarding the post-resectional and the processing of the specimen, do you advise to separate the lymph nodes by the surgeon, or you send it en bloc to the pathologist? Because the pathologist may not have that idea of like, because the lot of momentum will be there. Where is the like lymph nodes, and the possibility of identifying those lymphatic areas will be difficult for them. So what
Very
will you
nice
advise?
question. By the side, my surgeons postgraduate not there. You say pathologists don't have time to do, or they are not interested. But here our surgeons are not interested. These guys should see. This is more valid. Surgeons should do, dissect and show them it is better. But now we have dedicated pathologists for only our hospital for gastroenterology. So they do it everything dissection and give a very good pathology report of all the nodal regions. But of course we label the nodes group exactly where and give it to them.
Yeah, that's what I am asking, sir. So
Better.
you
Surgeons
process
should
it
do
like you resect it separately in the when you are
very
packing it up.
important. Your point is very important, and the surgeon
Because
should
you would have removed, but the pathologist might not have identified, because the lot of momentum is there. So everything looks fatty. So for
Correct.
them, identification will be very difficult.
Correct. Exactly. So now I'll show this gist, lesser curvature first, then go for fundus. And that liver, as usual, exposure is same way. left lobe liver, and there is a growth in this. I think I want to initiate shoes, and there is recently that this technique, this is from my point of view, right? We have done series of cases, no problem. But some surgeons in the Asian side, Japanese, will raise an objection. Should be, this is not that adequate enough. What they say, we'll see. This is a critical location where just to take it out. And left lobe, we put a retractor. This is an article published long time back. Now exposed to lesser sac, and now you can see there you can appreciate the bulge here. This is a growth here. And endoscopic guidance also will be used to mark the mucosal side, the extension of the growth. We take down the short gastric vessels. And now we go down adequate length of proximal and distal to the growth. We take down all the complete 2 layers of the lesser sac momentum and here.
ಬೇಗ ಪಾಸ್ ಮಾಡ್ಕೊಂಡ್ಬಿಡ್ಬಾರ್ದು ಏನು ಸರ್ ಅವ್ರು ಇಷ್ಟ ಅಂತಾರೆ ಇದೆಲ್ಲ ಚೆನ್ನಾಗಿ ಜ್ಞಾಪಕ ಇದೆ ನೀವು ವಾಟ್ ಐ ಮಾಡ್ಕೊಟ್ಟು ಅಲ್ಲಿ
It looks more of the extra luminal growth is more. Yes.
You can see this lesser momentum, they take it down. Even also we excise the lesser momentum later. That is a lesser curvature, the normal tissues this side. Now you can see we are reaching the other side, posterior wall of the stomach. We take down the small vessels and we enter the lesser sac. So we can approach the posterior wall and the anterior wall easily. Now you can appreciate here. This is a critical area, the location of the tumor. And now see, if I have to do it excise, and we have to remove a lot of lesser curvature of the part of the stomach also. So what we thought, this is umbrella net technique, and we can reduce the size of the seromuscular wall excision, but mucosa and tumor will be excised completely. See, we look at endoscopic marking and done, and beyond the margin of the tumor, and we incise only the seromuscular according to the level where we have seen, there we will go. This is normal stomach wall, and we divide the seromuscular only. And we can use a hook also, and this is little. See the marking done, and we are dividing this normal stomach wall. So you can see there it is. I think this is not the umbrella technique. It's a different excision only. Now you see, we take normal margin of the stomach wall. So, here we stitch together by stay suture, and
Shift that to.
yes,
Yeah.
this is for holding suture.
Okay. Sir, Dr. Palnivelu,
Yeah,
we'll go for 2 minutes to other theater and come back.
yeah, please. You are.
Sir, my concern.
Dr. Balakrishna, who is assisting you?
Madam.
Pakistan, sir.
Dr. Nisha is our from assistant professor from Mysore Medical College, sir.
Madam, why are you doing suctioning? Why don't you mop it? Suction sucks more and more blood. Is that hemostatic? Mop it. You are in a workshop. Don't send wrong messages. Who is the second assistant? Second assistant is your business to keep the field clean. Keep mopping.
Sir, it is a postgraduate, sir, second assistant.
That's okay. Then how are you going to teach them?
Yes, sir, yes, sir. Sorry, sir.
That's his business.
Yes, sir. Yes.
For postgraduate purpose, we are doing this in hands-on anastomosis. Even though it can be done by either whatever your preference, either stapler method or
Suturing method.
Usually, whenever we do a GJ, the mucosal layer, that means the inner layer, usually it is advisable to do interlocking for an hemostatic purpose. Any specific reason you are doing simple in this patient?
Question to you, Balakrishna.
Sir, I didn't hear you.
You are not doing, it's not a hemostatic stage. In GJ, it has to be a interlocking one. Every stitch has to be a interlocking one because it's a hemostatic. You are not doing that. Any particular reason he is asking?
It's your preference, sir.
No, it's wrong. The through and through, it is called through and through suture is hemostatic stitch. These is fundamentals. It's not a question of your wish or my wish. It is a hemostatic stitch. It has to be interlocked. If you are not doing interlocking, you have to change your approach towards locking. Every stitch needs to be locked. It's not colocolic.
Sir, we'll shift to Palani, sir. Palani,
Sir,
Yeah,
sir,
shift.
sir, just a minute, sir. Vijay Kumar, sir, want to explain this case, sir. Please hold on, sir.
Yeah.
Yes,
Can I
sir.
go ahead? Yeah.
Over to Vijay Kumar.
Can you hear me?
Loud and clear.
Yes, sir. Yes, sir.
Good morning, sir. Ashok Kumar, sir. How are you?
Good afternoon, Dr. Vijay.
How are you, sir?
First class.
We have lost sense of time here, sir. We are so engrossed in our work, sir.
Yeah, I know.
Thank you.
You have traveled all the way from Mangalore, no? You have to be.
Thank you. This is a case of CS stomach signet cell proved. Now they have done a laparoscopy. Dr. Dharmendra is doing the laparoscopy just to see what is happening. D-lap. And we saw some star-colored, very, very minimal fluid. We have taken it out and we are showing you the rest of the D-lap. The liver surface, everything is free, peritoneal is free. And we are now going ahead. He wants to demonstrate the role of ICG. Just for demonstration purposes, ICG is the role. Will you go ahead? ICG. As for the sake of postgraduates, the indocyanine green is being used extensively now for the lymphatics, as well as even some of the people are using it for seeing the vascularity at the anastomotic site, etc. Here we are, this is a CS stomach. He would like to show you the ICG role.
What we are expecting in the ICG imaging, sir?
Yeah.
Sir, you will present the case history, sir.
Carry on, carry on.
Yes.
So it's a 65-year-old male patient presenting with chief complaints of pain in epigastric region with decreased appetite, significant weight loss and early satiety in 6 months. Patient has underwent a open heart surgery 2 months ago for left atrial myxoma. So upper G endoscopy showed ulceroproliferative growth in the antropyloric region. This was the video of upper G endoscopy. CCT was done. CCT showed asymmetrical circumferential short segment wall thickening in the antropyloric region with partial obstruction of the stomach. There was no obvious perigastric stranding and no lymphadenopathy. Histopathology showed signet ring cell carcinoma. This is a CT video.
Audience, can you see the ICG there?
Yeah, yes. Sir.
Hello?
Yes, sir.
1 cc IV has been given a few minutes back. We are trying to see whether we could see any perigastric lymph nodes, etc.
Vijay, please tell me what is the perigastric lymph nodes you were talking about. If you see, what is it?
No, sir, I told you this is only for ICG demonstration. Dharmendra wanted to do, I said in the beginning only, sir.
Okay, sir.
Just to show off, sir.
Sir, surgery department, they're trying to get a ICG, this thing. So we thought...
you are just showing the demo, sir, that's it.
It has no relevance in gastric cancers, right?
Yes, sir. Very beautifully will be demonstrated only in, as I understood, but very nicely, thoracic duct.
To say that it has no relevance in gastric cancer is wrong. Can I tell you what relevance it has?
Please, sir.
Yes.
Continue, sir. Continue, sir.
First, it is to identify the sentinel node. So what you have to do is that 48 hours before the surgery, you inject the ICG into the tumor.
Tumor, that is.
And then on the table, you use the ICG to look at the lymph node to see the sentinel lymph node. Okay, and that sentinel lymph node you can biopsy it. If it is negative, then
You need
usually
not do-
skip nodes are not common, so you need not do a full radical dissection. So this is one of the uses of the
ICG.
ICG in stomach,
Gastric cancer.
in gastric
If I
cancer.
may interrupt,
Yeah.
is this evidence-based?
Yes.
Role of a sentinel node in CA stomach? Is
Yes,
it
yes, all this
evidence-based?
is evidence based. There are studies. There are some people, the Japanese, who believe very strongly in it. But I don't know what is the evidence. I can't quote to you the evidence, but this is what has been done. And
No, I'm sorry, I don't
it has
think
been done for the
evidence-based.
esophagus
For
also.
CA stomach, it is not evidence-based.
No, it is, I think. There are papers on it, and they have shown that this the sentinel node can be biopsied. Now, whether it is worth not doing the lymph node dissection if the sentinel node is negative, I don't know whether there is any evidence for that. I'm not sure. But people have done this, and they have shown that it can be done. So now that the ICG is available, there are so many indications coming up for it every day. There are new indications. Now, for example, colorectal liver metastasis, surface metastasis. What you do is you give the ICG 7 days in advance and then wait. And then on the day of surgery, you go in. The rest of the liver will wash it out, but the colorectal secondaries will hold on to the ICG, especially on the surface. Then you can easily mark them and take them out. Okay, so these are all new things that are coming. So the ICG has got so many new indications that, for example, in the stomach, if you have a stricture of the stomach and the esophagus and you are putting a colon bypass, we are using the ICG after mobilizing the colon to see the blood flow of the colon. It is much better seen with the ICG than seen with the naked eye. So many times we have thought it is color is all right, but when the ICG is given, it doesn't appear or takes a long time to appear. So then we have to trim that colon edge before doing the anastomosis. And people have shown that you reduce the leak rate from 10 to 12% to 3% if you do this ICG. So colonic surgery also we are doing it. All anterior sections, right hemicolectomy, we give ICG and make sure that the ends are well vascularized. Now, what is well vascularized? The ICG must appear in that bowel at the same time as it appears in the small intestine. So once it appears equally, then it's well vascularized. If there is a 30-second delay between the end of the colon getting it and the small bowel getting it, the bowel is not very well perfused. You'll have to resect a little bit of the bowel. And we have been, I think, I can't give you exact details of how many leaks we have stopped, but since we have started doing this, the feeling is that the leaks have gone down.
Thank you, sir. Thanks for enlightening us on the ICG. I think we'll move on to the other agenda. I think they're waiting. Palnivellu, sir.
Sir, Dr. Palli, sir, we are with you.
We are unable to hear.
Dr. Palli?
Sir, this is Dr. Ramesh here to support him, sir. He is just
Yeah,
went
sir.
to see one patient outside, sir. He'll be coming now. Hello.
Yeah, we are seeing.
We are with you.
Sir, we are continuing the video.
Okay.
This is how we do sleeve resection of this just stomach whenever possible so that it doesn't produce obstruction. Sometimes the same thing is present in the fundus. It's easy to do a sleeve. Since it is present in the lesser curvature side, we just open it and then we give enough margin and then do a stapler. Since it is the distal part, we are using that yellow cartridge for staplering. So 1 centimeter clearance is enough for just stomach. Only thing is this capsule of the tumor, we should not open the capsule or it should not spill. If necessary, we may have to go for one more cartridge also, one more stapler also. One more is. So we should make sure that adequate space is there in the greater curvature site so that the whatever food they take, it drains well. And never take a chance. You have to put, if you have any doubt, you have to go for another stapler instead of putting a clip.
So we'll be keep seeing you, sir. We'll be shifting to other OT. They're opening the.
So we are completing with one more stapler, sir. That's all. And we put the specimen in a bag and we are going to remove it.
Okay.
Okay, thank you, sir. We are going to the other theater.
Thank you, sir.
The case is going to be opened. We are with who is operating?
Dr. Vijay Kumar is operating, sir.
Oh, okay.
It is operable.
Dr. Vijay,
Am I audible?
you are very well audible. We are with you, Vijay.
Thank you, sir.
Both audio and video are on. Better be careful.
Thank you very much, sir. Yes, you are always with me, sir. Thank
Yeah,
you.
definitely.
Thank you, sir. Thank you, sir.
Dr. Vijay.
Yes, sir. Please carry on, sir.
Certain things we have to learn from senior surgeons like Ramesh Arthanari.
Thank you, sir.
Okay, like what?
I don't know, sir.
Open and closure, he will give it to assistant. GJ, he will give it to assistant.
Pardon me, sir?
Open and closure, he gives it to assistant.
Sir, I asked them to open, they refused, sir.
They are scared what to do. Vice Chancellor is here.
When I went to wash up, I told them, please open. They said no. No answers
Scared
for
of you.
them.
That's it.
So they have to learn from their seniors, sir.
Okay, if you say so.
When diagnostic lab only I asked them to do, sir. Why not open?
I don't know what transpired between you people. What I am seeing, we are seeing. I make a comment. That's it.
Mop it, so keep the mop in your hand. Mop when I ask you to. Mop. Mop, madam. See, we are under magnified cameras. Even small bleeding will look more there.
Bigger here.
So we keep on mopping.
I request Dr. Mahesh Shetty sir, Dr. Harish sir, Dr. K. Arvind sir to join the session and chair the session.
Not only chairing, moderating the session, madam. They have to moderate. Yeah, you tell them. Request them.
Nice. Can you see the tumor? Can you see the tumor?
Yes, Vijay, the chairpersons are taking little time to settle down.
Thank you, sir. Thank you. This is in the pylorus end, antrum. You are able to see the serosal involvement here. Yeah.
You are lucky, patient also lucky, yeah?
Thank you, sir. I didn't wash up till Dharmendra said it is operable.
But ಒಳಗೋದ್ಮೇಲೆ ತಾನೇ ಗೊತ್ತಾಗೋದು.
Knife. This is what the comment I made. Who did this? Yeah. Now you see, it's unnecessarily one. Transverse is coming. Suppose you put a vertical here, things would have been different, right?
Okay, you are skirting the umbilicus to the right, doesn't matter, Vijay.
Pardon me, sir?
You are skirting the umbilicus to the right with a long midline incision.
Thank you, sir. I'm doing something else here.
No, the same thing. You have that port you are talking about, isn't it?
I was telling them to put the port supraumbilicus, and for what and all I explained. So I told them that that's it. That's it. Bleeding. After good, Bible. Is good. Let me try. Let me try. Mop. This is because it is working. Okay. It's not okay. Okay, it's working. I don't think so. There is it working? Which one I have to press? Press the foot or one?
Sir, Dr. Harish here, sir.
Please do it. I'm not seeing. I'm checking the ligature they are given, sir.
Sir, this is for the postgraduates. One question from my side. When the diagnostic laparoscopy is done, what are all the things we have to look to assess the operability?
No, man. It's not, no, it's not working. What you're telling? It may be working there, dear. It's not working here. Understand? Working. What should I tell? You just see. Now it is working. Then also it is not coagulating. That is why I'm doing it on the surface before going in. No. Yeah.
For surface bleeding.
Come. Somebody come here. Somebody come here, please. Mop it, Mop tagoli, mop please. One. Retractor kodama. One more retract. You hold this. You hold. I'm going ahead with the omentectomy.
Harish, you asked some question, you can ask now. Sir is now is
free.
So my question was like, in diagnostic laparoscopy, what are the things we look into, like when we are assessing for operability?
Sir, Vijay Kumar sir, for you, sir.
Audio is not working.
Right. Hold this. We'll try to enter the lesser set. Okay. Hold. 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 Wait. Just hold like that. Mop. Are they with me? Hello.
Yeah, now we are with you. You are completely gone off the audio.
Now you are able to see me, sir?
She is there, audio is not there. The Harish has been asking repeatedly a question which selective definitely you didn't answer. Dr. Over Dr. Harish.
Is it? What is the question? Mop. எனக்கு ஒரு மாப் கொடுங்க இடம். See, when you are doing a demo, understand W should show that there won't be any blood at all. What you think not even 1 ml will be, they will not be able to see properly. Yeah. I'm going to the lesser momentum. I told you to give a mop for me here, please. I am on the loop. I can't search, no? Right. So this is the colon, transverse colon. This is the stomach, greater curve, and the momentum I have taken on the other side. So I have entered into the lesser sac to see whether I can lift the tumor from the pancreas. That is what I have done now, and the tumor is in my hand. Tumor is in my hand, and I have mopped it, and what you are seeing is the pancreas.
Rather, you have completely lifted the third layer.
Yes, sir.
That's it.
Just don't do anything. Don't do anything.
Sir, is there still a role of a bursectomy in this patient, in the CS stomach,
It
sir?
will be flimsy. Connections will be there here. You
Vijay
tear.
Kumar,
You will be tearing either the middle colon.
Vijay Kumar, sir,
Yes.
is there a role of bursectomy in CS stomach, sir, now?
Vasectomy I am doing here. One as a routine. Number two, whether it should be done or not is the question. When it is not involving the serosa, it need not be done. That is the consensus now. Here you see, particularly when it is posteriorly placed in serosa, you have to do. Otherwise, you need not do. Here you see it is not on the lesser sac, but it is serosal involvement on this side. Okay, right. So total vasectomy need not be done is the point. Yeah, just leave.
Sir, wait Vijay,
yes, sir.
We are watching your dissection.
Yes, sir.
Palli sir is waiting there in Gem.
Yes, sir.
We will just go to him and come back.
Please, sir.
Right. Thank you. Over to Gem. Sir, Dr. Palli, we are with you, sir.
Yeah.
Over to Dr. Harish.
Good morning, sir.
Hello.
Good morning, sir. Please, sir.
Good morning. Good morning. Yeah. Now I'll show fundal gastric, one and a different one. I think it is so you can appreciate the tumor now. It is in the greater curvature on the fundus part of the stomach. And now you can see the short gastric vessels. And you can appreciate the tumor here. And before applying stapler, we have to prepare the stomach by releasing the short gastric vessels. Now you can see short gastric vessels were released, the stomach is free. See, now you can appreciate now that once prepared, then we can go for stapling. This is simple excision. If you think it is going to compromise the stomach gastric or lumen, then we have to adapt different technique. But this is a excess of the fundus only we remove. Then second cartridge.
Sir, when do you choose to do laparoscopically and when do you choose to go for open surgery, sir? I know. All based on the size.
Laparoscopic or robotic, no open.
No, based on the size, do you have any criteria to decide?
Some cases, no. Criteria, every patients we do minimally invasive. Some cases I may do assisted like, and this is a different one. So I have not done any open cases, this type of lesion recently. Now you can see, previously you saw one type different tumor. Now same lesser curvature, I am showing a different technique. See, I am making endoscopic Maidens inside of a mark, exactly where the mucosal extension of the tumor. Now outside we make it up. This is a net technique which I was mentioning, and this is a one. See, seromuscular. We don't divide the lumen. And seromuscular, I have to remove more my mucosa. So what we do, prepare it like this. Then we use a stapler. Excision is complete, and mucosa also widely we take it out. But seromuscular wall for lesser curvature I am preserving just for reconstruction purpose. See, now it has been divided. And I think one more cartridge. Yeah. This is only mucosa. We have to use white cartridge, not like a stomach and a blue. So now we have to reconstruct here the seromuscular wall which we open. Now we are reconstructing it. Sometimes some tumor may be involving the distal pancreas, huge giant, and that type of cases, manipulation difficult, and those cases better to do open and doing it. That also diagnostic can do, mobilize all round, then may open and doing it. See, endoscopically we look at inside and this one. And sometimes also some lesion has to be done with the laparoscopy, endoscopy combined approach. Renduous, what we call here. Now look at here. This is a duodenal jejunum. I am putting a occlusion of the jejunum, inflating the stomach, and duodenal. See, this is a tumor. Look and approach very close to OG junction. So this has to be carefully done. Otherwise, OG junction will get here. Now you see, we go into the lumen. And that day when I was doing it, I did not have a balloon trocar. Balloon trocar is a good thing then you can do, but I taken a stitch inside and passing through. So we keep endoscopic flex, endoflex, retroflexion, then we doing it. And here inside we can take it out to only the mucosal excision, or even a muscular wall also can be excised, no problem. Say no balloon trocar, but somehow or other we made an attempt to do, you can appreciate inside. Just to prevent a gas leak. Sometimes this is a problem. Balloon trocar would have been inflated, nicely given a traction, would have been much easier. Okay. Now inflated the stomach, you can see inside nicely now. So now this is a lesion, we go all around making an incision. One can use a hook or a harmonic. Okay, now excise. So we can suture it intracorporeally, same way. Suppose in case it has to be taken the muscular also, no problem, that same reconstruction can be done, including the muscular wall. Full thickness we can take it and doing it. And now we have a V-lock, absorbable sutures, and very well we can suture very easily there. Particularly mucosal only 30 is good enough. See, OG junction is not disrupted. We are able to do it using with the help of endoscope, identifying the exact lesions. If you don't use endoscope, you can make use of this one. Now you can, the tumor, put a bag, and this also can be removed through by oral putting a plastic, and endoscope can be pulled out same way. And many times we have removed even a sleeve section by mouth. Single incision courses then I've done. So after removal this now we reconstruct the trocar entries. So anyone on this technique to do it is a good technique, provided one should have a balloon trocar and endoscopic assistance, and can be done very well. And different location makes a problem. Okay. Now other purpose. Any question here, and you can ask me now.
No, that's an excellent, sir. All the three varieties what you showed. The duodenal gist, can you, is it possible to show a duodenal gist? Duodenal gist?
Pardon? Yeah, Ashok?
Duodenal gist or duodenal tumors, anything?
Yeah, I'll show you
Next.
now.
Yeah,
I'm
right.
going to show
Yes, sir.
now.
So in the meantime, we will go to that other theater, sir.
Adida.
We will go to other theater.
Eh?
We will swap to the other theater.
Pardon? Is it? And you go to theatre, come back, I will better.
Yes,
Yeah.
sir. Yes, sir. You get ready
Yes,
in the
sir.
meantime. Thank you, sir.
Sir, Vijay Kumar is there, sir.
Dr. Vijay, we are with you, Vijay.
Yes, sir. Can you see what I am doing, sir?
Yeah, Dr. Harish will take over.
Hello.
Sir.
Can you see what I am doing?
Yes, sir, but I think we had lost audio, so we are not able to.
No, fine. The orientation, you can see the tumor is in my hand.
Yes, sir.
This is antrum. I am holding the pylorus and the duodenum in my hand. Hello.
Yes, sir.
And we are on the pancreatic head. This is the pancreatic head. So we are going to dissect the subpylori group of nodes and the same time handle the right gastroepiploic vessels, vein and the artery. Can you see that?
Yes, sir.
Here I was just telling them, you should be very careful here because it will tear in the vein, means it can be a tear in the indirectly the superior mesenteric vein where it will join. So that is where you should be careful in one. And two, when you are doing a tubing of the for esophagectomy, again the same thing, you should save these vessels. You can see the node there.
Yes, sir.
A small node there. We will be taking it out. Can you hold this with that hand? Forces to me. ಸ್ವಲ್ಪ ಸಣ್ಣದು ಬೇಕಮ್ಮ 4 cells ಸ್ವಲ್ಪ ಸಣ್ಣದು Why there is so much noise when they come from
Sir, what is your chosen instrument for dissection? Is all cases do you use ligashore?
I'm not able to hear whom they are talking.
Sir, we wanted to know if you use ligashore for all your dissections.
Wherever there is what is available, I use ligashore. I am very comfortable with. If ligashore is not there, I use monopolar, bipolar, whatever.
He is asking for dissection, Vijay.
That's what I am also telling, sir. When it is there,
that means you are telling all the boys that ligashore or harmonic or monopolar, you use it for dissection, right?
Yes, sir.
I don't. I use rather mixtures, the right angle forceps.
Correct, sir. That's what I said. What is available, I use. I said here ligashore is there, so I am happily doing it so that the demonstration also become little more bloodless. You can see the superior mesenteric vein there.
Yes, sir. Yes, sir.
This is what I was telling. A tear here may result in a tear of the superior mesenteric vein. You can see the vein joining there. This is the middle colic vein, but this is what is joining there. That is what I was telling. Hold it. When ligashore is not there, what will you do? The question, if it comes, I use mixture also, sir. Mixture. Mixed right angle, no? Sannadi. For the lymphatic clearances, etc., mixture, etc., is good, sir. Sorry, harmonic, as well as ligashore. Whereas you see that when you are trying to hook the vessel, etc., I am using clip with the what is that? Is it? What is it? What have you got for Alama tie in the Kodama 30 tie? ಹಲೋ, ಹಿಂಗೆ ನಂದು ಮೈಕ್ ಇರುವಾಗ ದಯವಿಟ್ಟು ನೀವು ಮಾತಾಡಬೇಡಿ, ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳಿ ದಯವಿಟ್ಟು, ಆಯ್ತಾ? ಪ್ಲೀಸ್ ಬನ್ನಿ. ಏನಮ್ಮ ಇದು ವೆಹಿಕಲ್ 30 ಆ ಕಡೆ ಕೊಡಮ್ಮ. Because the question came, I am going to answer here. For example, in a setup where clips are there, I would have used clips. Now I am using barber thread on the other side, on the one side, and this side I am putting vicryl. Hold this. Don't do it.
Why waste vicryl, Vijay? Why not Borbos linen?
Barber is on
Time
that
tested.
side I have put, sir.
Both sides also you can use it, no?
You can use whatever you want to, sir. I
Agreed,
prefer
why you waste resources, Vijay?
No,
Try
no,
to
no.
bring
Vicryl,
down.
no, sir. That I am not going to agree.
Yeah,
Resources.
tell me the only one good reason.
See.
What is the great difference between vicryl and this Borbos linen?
Thank you, sir.
In a situation like this,
Particularly,
the vessels.
particularly when vicryl is one absorbable 30, I use
So
it on
what?
the patient side,
Right.
and on the linen side, I use it for the specimen, hoping that it will not only save 50% of the money, but at the same time will not compromise anywhere anything.
Where compromise? Tell me. There should be valid reasoning between vicryl and Borbos linen to ligate these vessels.
I don't know, sir, whether they have done any study, sir.
Better you take up the study and then come out.
Yeah.
So that would be a
Till
better
that time, we will be going with what we feel.
No, I will
is
tell the
working.
boys, Borbos linen is the best test, time tested for centuries. It has been there. Boys, girls, don't jump into the resources, waste of resources like this.
Correct, sir. That way I should not be using Ligashur also, sir.
Exactly. Where I am coming to.
You should not be using Ligashur, you should not be using Robo, you should not be using laparoscopy resources.
I don't mean that. I don't mean that. In a workshop like this, you send, say, but these people have come to learn the tricks of the trade.
Correct.
The legacy is not available. What are they supposed to do?
Dr.
That's all the
Ashok,
issues.
Dr. Ashok,
Yeah.
just to extend the argument, at this juncture, say where he is trying to dissect the gastrocolic trunk, which is absolutely a fragile vein, I wouldn't think of using barber's linen, which is a braided, rough, and it cuts through.
Sir,
I would rather
it
use
is
a monofilament.
ligating that vein. He has dissected off with mixtures,
Yes.
and when the mixtures was passed, you easily take this like Borbos linen. And the tying, it depends. It should not do a seesaw-like movement. You are ligating it properly. For centuries, it has been done. Vicryl was there when we were all students. Haven't we grown up using this Borbos linen? That argument I will not agree, sir.
So we were not ligating these fragile veins those days. These veins are
course.
absolutely fragile, and a braided thread is dangerous here. That
No,
is all
if
I'm
the-
saying.
if
When you
the-
are,
if the
when you
braided-
are
if the-
particularly teaching a young person, they should rather use a monofilament thread here or use a clip.
Dr. Harish asked him the ligature role. Always you use ligature for dissection.
Sir, the other thing about linen and vicryl, what I wanted to tell is sometimes they autoclave it multiple times. So thread in this area is little dangerous. If available and patient can afford, I think vicryl tie is better.
Give the both options, no. Don't repeatedly use the autoclaved Borbos linen.
Mop. See, they are showing. They have to skip seeing.
Yeah.
Sir, Vijay Kumar sir will go to Dr. Palanivel
Please,
now.
please.
Yes,
Hello.
Sir.
Hello.
Yes, sir. We are able to hear you, sir.
Yeah. So now I'll go for duodenal net. Now we'll see. Duodenal is it? So we start mobilizing this gastrocolic omentum. That is a duodenum. And you can appreciate that vessels coming to the duodenum will take it down. Small bleeder. This is second part. And we do a coccus maneuver, and in case you need to excise it completely, the part 1 or 2, we need. We can appreciate the IVC, and we go a coccus maneuver.
What was the size of the tumor here, sir?
Pardon?
What was the size of the tumor?
And I have to see myself. I don't, sorry. I asked Pasupati, took the video done long time back. I don't know the size. It must be small, that does not visibly seen. So this first part of duodenum taken from the posteriorly, and now this is, you can appreciate, this is the second, and look at this is a pancreas. We can make a window, and duodenectomy proximal, and duodenectomy distal, duodenectomy complete, head preserving pancreas. So that way it is a nice way. Now you look at this, we are separating the duodenum from the pancreas, taking out. And the medial wall, if a tumor is there, there is not possibility. Part 1 duodenum different, and here now we dividing it distal to the polyp. Endoscopy guidance very important to take it out. Now this is a seromuscular wall, and carefully separating from the pancreas. Posterior. And some tumor, what in this particular case, I did a coccus maneuver mainly, and I think I remember there was a nodal enlargement like. So that's why we want to do a lymphadenectomy as well there, and we were taking up. So we saw the polyp inside, doubtful where exactly. Now we seen, then we dividing it here. What you saw is the ampulla. You can appreciate there. You can see the ampulla. That's why we left that this one and for reconstruction. This is for the stomach, duodeno, gastrojejunostomy, end to side. Now we are going for the reconstruction into the ampulla. So we are taking to the supracholic compartment. Now we make a opening for enterostomy for anastomosis. If it is a part 1, this is not necessary. Only part 2, this problem will come. And in fact, we put a stent, we want to know exactly, then we removed it. Now you look at, we are going to reconstruct the ampulla to this. We use a 3-0.
30 PDS, sir?
A PDS, yes. The PDS is better here. And here pancreatic fluid and bile both will be coming, and the safety is. And now you can appreciate full thickness of the wall, we can see, and interrupt suture is the preferred. The suction tip helps us retracting the head by lifting it. This is pancreatic duct. Are you able to appreciate?
Yes, sir, we can make out.
Pancreatic duct, yeah. Sometimes we'll keep a stent, then we suturing it if it is very close.
Have you encountered a stenosis or a stricture, sir, after this?
No, number of cases wise, very not much, and so far no, I have not come across, and the possibility is more, but we have a highlight that anastomosis stricture, not here, and see, this is a normal duct mucosa, so I don't no problem here. It is like when we do a Whipple bile duct and the pancreatic duct through jejunum, rarely we come across stricture, no? That way
Yes.
similarly here also. This is in fact is normal, ampulla we keeping it anastomosing. Posteriorly I did interrupted, anteriorly keeping a stent, I am continuous suturing now. And in this particular case, posterior pancreatic lymph nodes all be cleared. Their anastomosis, Roux-en-Y complete anastomosis. Okay, now what we'll do, I'll show another interesting tumor at the OG junction where we need a resection anastomosis, a benign tumor. I think
Okay.
this is okay. I'll go to that one. This is like virtual live. I'll show a little longer. If time permits, fine. It's okay?
Yes, sir. You
Yeah.
can do.
Yeah. See, there is a tumor in the OG junction, lower end esophagus. That is a stomach.
Sir, 1 minute, sir. Dr. Vijay Kumar wants to say something here, sir.
Yeah,
1
please
minute.
go ahead. Come back.
Over to Dr. Vijay Kumar, sir.
Yeah, can you now see the anatomy here? It's artery.
Yes, sir.
The vein has been cut here. It has gone that side. This is the pancreas, and you see that artery. Before ligating the artery, I thought I'll show you. That's all. This. What I'm trying to say is, vein will go this side, artery will come from here. So both will not accompany. So vein is more important for the simple reason, as I said, it will be joining the supramesenteric vein. Any tear, unnecessary problems. Now that is taken care of, and you can see the clearance also. The lymph nodal clearance, you see the whole thing is denuded and we are waiting, right?
Yes, sir.
Thank you. You can go that side. Thank you.
Thank you, sir. Sir, Palanina, sir.
Yeah. Now there was a lymph node. We took the lymph node for biopsy. Frozen, we will be doing it. Then we'll. Now this is preparing the lesser curvature and the lower end esophagus. We could not preserve that OG junctions. We have to resect it. This particular case. This is a lesser right cross, and go between the cross and the esophagus. This is another energy source, thunderbeat.
In what way it is different from our regular harmonic scalpel, sir?
Yeah, this is a combined bipolar and the ultrasonic together. And this, it is coagulates and cuts tissues, but same purpose only be using it. But harmonic, of course, we are able to reuse it more number of cases. Thunderbeat, no, very limited number of cases. But company recommends only single use.
Sir, size of the vessel which it can seal, sir. Maximum size of the vessel.
Up to 7 millimeter we can. And coagulation, division, everything can be done. And harmonic ligation should also recommended for 7 mm vessels. This is coagulating effect more than that, so it can be, but same purpose.
Lateral spread of energy, sir.
Is much less here, and corner. But now that is what it is nowhere harmonic case or here everyone harmonic case still of course more. Liga should the end of the stapler is without much energy. Thunderbit also similarly. See, now you mobilized it, you can appreciate the tumor. Posteriorly also dividing it. Okay. Now we scrutinize the tissues. Vagus nerve, which my left hand is holding, is the vagus nerve, left anti-vagus nerve. We wanted to preserve the nerve, so we take it out here.
Is there any specific reason to preserve, sir, or?
Yeah, any benign tumor, when we doing it, it's better preserved. Second thing is, and gastric emptying will be better. That's why. Always, when a benign tumor, always preserve. Achalasia, regular fundoplication, this tumor. Now I'm trying to see that I can enucleate, attempt to do, but then finally we decided it is not possible to this one. See, the muscle is completely has been replaced small, it is not going to help.
Sir, is it leiomyoma, lower end esophagus?
Yeah. They are going to come resection. Okay. So you can appreciate the O junction circular and sling fibers.
Yes, sir.
Finally got opened. You can see the tumor is going so high.
Yes, sir.
Yeah. We mobilize esophagus little more and you can appreciate the vagus now there.
Yes, sir.
Left there you can appreciate mediastinal pleura. That is where it's going out posteriorly. This extended mediastinal dissection is very important if for reconstruction mainly.
To mobilize the lower right.
Now preparing the stomach side also, taking all this momentum.
Don't use a sling, sir, to give traction.
Yeah, if necessary, then we'll put up because tumor at the OG junction cell, no sling where to put, no, little doubtful, correct place will not be there. So that's why sling not there, we'll see. But anyway, we are able to get it adequate way, expose, push. Now this is OG junction, right side of this, that is a now posterior now. I'm holding it now. Posterior now it is injured, it's okay, no problem. Generally it is a secretor now, most of them. But anterior more of motor now, always better preserved. So that postoperative problem of delayed gastric emptying will be minimized. So greater curvature to be taking down the short gastric vessels.
Which is faster to cut, sir? Ligasure or, harmonic or this thunderbeat, sir? Coagulate and cut.
Thunderbeat recently I'm not doing it. Thunderbeat and harmonic time more or less same. But ligasure faster.
Yes.
But ligasure is mainly for coagulation the cutting. And this thunderbeat and harmonic is a dissection, coagulation, cutting.
Okay, sir.
See, now we divide the stomach distal to the tumor adequately. This is a less curvature including it. One more cartridge. So, though it is benign tumor, but the surgery varies. Cancer is all standard, same technique unless it is advanced. Benign tumor is location may decides a type of treatment. More important is technically.
We are preserving stomach. Obviously, we have to plan the surgery.
Yeah, that's why Ashok was very particular. Wanted to see a gist and tumor in the stomach. So different way. That so now distal division is fine. Now we are going for the proximal. So obviously it goes into the mediastinum. So we have a stay suture, and hiatus can be widened. That way, otherwise difficult. One stay on the left side. Now right side. I think the vagus nerve also comes in the dissection now. After all dissection, then we are including it. So specimen is free now. Esophagus is gone inside. And obviously only circular stapler is feasible in this case. Otherwise you have to go thoracoscopic approach for a reconstruction.
Sir, this case, because the lumen was opened, your idea was to do transection, resection and anastomosis?
Yeah, I could see the tumor going more. By excising enucleation, stomach-esophageal wall not going to be functionally. And it is almost, taking more than 50% of the stomach wall. And I don't want to compromise quality. That's why after decision was changed.
If would have been able to excise without opening the lumen and from outside, probably that would have been enough?
Yeah. And this is, I think, the decision was later only. Actually, trial dissection I always trying to do, but it was well prepared for necessary. We will go for resection. Now this is Arvel. We applied it 25, and we make a pursing suture to hold. This pursing suture, if you don't do it, sometimes this anvil will comes out of the end. It's a problem. Now I can even a slightly traction I can give it. Now we'll remove it. Now we open the stomach. So similar way, like shown, one of the trocar we made it larger water entry and passing it to this. Plastic tube is pulled back, and you can appreciate the size nicely, 25. And always appears to the greater curvature side to come. The vascularity will not be compromised. Better not to come at the tip mostly. Now it is side, and now it is piercing it. And the brown appearance that shows it is come back. Yeah, it got locked. So this goes inside. I think this I more should have done the hiatus little more wider. Orville, a very nice, good for cervical anastomosis. Now you can see, and we can put the scope inside, also check it integrity, or after suturing, we can inflate and see. The plastic tube will go prevent infection. Now, that entry we suture back. And staple line also, if necessary, we can suture, few interrupted suture using 30. See, now looking at this way, but rather from above, if you come, will be very easy. See, now look at a good staple line. That is beyond is esophagus, down is. Okay, 25, but obviously looks wider, no? One case, I did it as a larger one. Finally, it is too wide. The patient will have more reflex then. Any question now? Any suggestion or any? And now we'll start. Vijay Kumar finished?
No, sir. He is
Okay.
still resecting, sir.
No delayed gastric emptying in this case, sir? Vagus was
I-
divided.
The next day, no, posterior vagus, yeah. Generally, we thought that vagus is 100% essential, but maybe a few days delay, and we gastrograph in VD next day or second posterior day to see emptying through pylorus. Generally, it works well, no problem. And if at all, then the medically we can put a lyseride or erythromycin into the stomach to stimulate the muscle. It comes out. So far, no problem.
Okay,
And but does not mean that which patient will develop better always preserve. This is a position of could preserve. Anterior, I dissected. I don't know why I wrongly applied, or I don't remember that why I divided the anterior vagus. Now we dissected. No, I should I
Yes,
should not have
yes, sir.
applied the stapler across. It is a mistake.
Did the patient have any dysphagia, sir?
The surgery before surgery.
No, sir. After the surgery,
After surgery,
because
no issues. Patient doing very fine. No problem.
25 size stapler was used.
No. 25, and rarely goes in the stricture, and but still possibility more than the linear stapler.
Sir, the esophagus, as I was telling, it can't take 28, more than 25 size, sir. 25
Yeah,
is
no,
25 millimeters.
yeah.
28 size, 29 size, it will not take, it might tear if you try to
Yeah.
force and introduce it.
Yeah, it is not taking, but to be found later, it is fine. But in esophagus and the chest,
Yeah.
25, the stricture rate very high.
Yes.
And OG junction, somewhere there, possibility is more, but we have not seen.
Sir, I will say my personal experience. I have done more than 80, 100 Sugviras, sir. In late 90s and all. 25 is the circular stapler what I used to use.
So,
Understand? They do, some patients, not all. 100 out of 100 or 10 out of 10 will not come back with stricture. Few people will do come back. And one or two dilatations of Savary Giard. Initially, I did a balloon dilator like a fool. It got punctured. Then I realized, because stainless steel staplers are there, titanium, definitely it has punctured. Subsequently, I started using only Savary Giard dilators. One or two dilatations, that's it, and patient is perfectly fine.
yeah.
That's my personal experience.
Yeah. The comment is circular stapler. If start functioning from day 3, 4, and the food passing, it dilates, keeping it strictureless.
Correct.
But if you delay, then it goes. But in case of intrathoracic anastomosis of the neck, circular stapler, whether patient complained dysphagia or not, every institute should have a protocol, put an endoscope to see, and by 30 days, and put a scope. If you think it is going to narrow, balloon dilatation gives way. That is better.
Sir, balloon you can't. Balloon, no. It will get punctured. Savary Giard is a dilator. Yes, sir. Titanium staplers, they will puncture the max force or CRE balloons, sir. It is a puncture. Yes, sir. Savary Giard is the best test.
But the OG junction, somewhere we start feeling it. I don't know why it is. No, it is not happening yet. Okay. Any question? Anything now, Ashok?
Questions are going on now, sir. Audience, my dear delegates, sir
Anything
wants to know.
Otherwise, I'll take later. Very wonderful, and we'll try to go to Mysore to see our friends and soon.
Excellent, sir.
Yeah.
So shall we permit him to leave the our operation theatre, and Jem itself will be leaving. Is it okay, boys, girls?
Yeah.
Okay.
Thank you very much for that.
Thank you, sir. A standing ovation, please.
All
Sir, do you hear the audience clapping? A standing ovation, sir. A standing ovation. Video. Yeah.
Thank you. Always. Our
Thank you,
friends
sir.
always do that. Thank you. Bye.
Thank you, sir.
Thank you.
Dr. Vijay Kumar, we are with you.
Yes, sir. I'm waiting for you to join, sir.
Yeah, join.
Yeah, can you see this? What I am doing?
Fire.
No, are you able to see that, sir?
Yes, sir. Yes, sir.
Yeah, I'm using the staplers for the duodenum, sir. After cutting, I will show you where we are cutting. Yes.
Vijay Kumar, sir.
Yeah, please.
Next the test ready. We will present the case history and come back to you, sir.
Yeah, please.
Yeah, thank you, sir.
Dr. Ramesh Ardnari is here now. Welcome, sir.
This would be the last case from MMCRI. Here comes a 45 years old female patient with complaints of pain over the right hypochondrium since 2 years and complaints of discomfort in the upper abdomen on intake of spicy and oily foods, with history of open cholecystectomy 20 years ago and history of open mesh repair for incisional hernia post cholecystectomy 7 years ago, and history of tobacco chewing abstinence since 2 years. So this is how the CECT abdomen and pelvis of the patient looks like, with a polypoidal intraluminal lesion measuring about 2.7 into 2.4 into 2.2 centimeter noted in the lesser curvature of the stomach near the antral region. And the endoscopy is as like this, with the polyp noted at the lesser curvature of the stomach, and the histopath comes as inflammatory polyp with hypoplastic lining.
If you have all the
This is the polyp which is seen
you
in the
can
endoscopy.
remove with an endoscope this polyp